Fantastic. It's 10 o'clock and we're going to start right now. Hi, I'm Robin Shapiro and I'm the board chair and co-founder of WASHA, the Washington State Health Advocacy Association. WASHA is a not-for-profit focused on helping people transform from patient to active participant and partner in your health. We do this through raising awareness about what health advocacy is, teaching health advocacy skills, and connecting people to health advocacy resources. Our programs are made possible by the generous support of individuals like you, professionals, members, partners, companies. If you'd like to learn more about WASHA or join our community, please sign up for our e-newsletter or become a member at www.washa.org. Before we begin, I'd like to provide you with a few reminders. Please make sure that your microphone is on mute to help us ensure that the sound quality is optimal for everyone. I would like to remind people that we are recording this webinar, which will be available after this live presentation. And so chats and things will be on the recording. For questions, we will be handling that either through the Q&A function that's at the bottom of your screen called Q&A, or you can also send questions or comments through the chat function. I'm going to type into the chat window, and if you could just let me know that you can see it and respond, that would be great. I'm going to do that right now. Typing here. And it looks like people are signing in well. Dana will be answering questions at the end of her presentation, but you can pose questions in the Q&A section or through the chat function at any time. If you have technical difficulties, please send those to Ashley Carlson in the chat window. And if you have difficulty with that, you can also send it to info@washa.org. And with that, I would like to introduce our wonderful speaker for today. Dana Hutson is founder of Cancer Champions, which helps individuals and families gain clarity in the confusion of cancer diagnosis. Prior to founding Cancer Champions, Dana gained her oncology experience in her 25-year career within the biopharma industry. Dana is a Campaign Zero Families for Patient Safety community educator, immediate past president of the National Association of Women Business Owners of Greater Washington, D.C., and serves on the boards of SDI Foundation for Education and the Samaritan Ministry of Greater Washington. And with that, I would like to thank Dana and hand it over to her. Thank you, Dana.
Robin, thank you. And thank you to everybody that has carved out some time in their day today to be with us. I know there's a lot of things that are competing for our time, and I appreciate. Rob, there's the quick poll is still in the middle of the screen for me. There, thank you. Thank you. So like Robin said, I am a board certified health advocate. I'm the founder of Cancer Champions, and it's my pleasure today to share some information about a relatively new phenomenon in healthcare called financial toxicity, and how we can minimize the financial burdens of healthcare costs. So with that, I'm just going to get started. I wanted to just share with you a little bit of my background, just so you can understand why I feel I'm qualified to speak to this topic today. The picture up in the top left-hand corner is my granddad, and he was a physician. And actually, just a fun fact, he was the prison doctor here. I'm right outside Washington, D.C., and he was the prison doctor here at a big penitentiary back in the 50s. Then he opened his private practice, and I was always around medicine and healthcare professionals, and I just thought that's going to be my path. That's what I should do. And then I went to school. I went to college, and organic chemistry weeded me right out, just like it's supposed to. And I found out that I needed to pivot, and I went to the business school. But I never wanted to stay far away from healthcare and doctors and science. And so I took my marketing business background and went into biopharma and never looked back. So like Robin said, I had a 25-year career within the healthcare industry, primarily in oncology, which is the study of cancer. and loved every minute of it until my father, who is in the bottom left-hand photograph, was diagnosed with cholangiocarcinoma a few years ago. And it was during that journey that I really was thrown on the other side of the fence and saw what it was like to be a daughter and a healthcare caregiver and just navigating the system. And it was there that I realized what a gap there was and what a need there was for people to come alongside people who are facing a devastating diagnosis and help them. So I left my job at Genentech and I started Cancer Champions, and now I'm a board certified patient advocate. So that's sort of my journey and how I amassed my knowledge, wisdom, for whatever that is. So what is financial toxicity? And I'm sure many of you have heard this terminology, and for some of you it may be new. It's just coming into the healthcare vernacular now in more of a mainstream way. It started in the cancer community, and it's Cancer, and for those of you that know this already, I apologize, but regimens for cancer treatment are pretty hard on a patient's body, right? And so there's a grading system, and they grade the toxicities of the regimens. So for instance, if you're getting something for breast cancer, they may grade 1, 2, 3, or 4, the level of the side effect that you're having from the treatment that you're getting. And they call that toxicities. They're the toxicities that are associated with the treatment that you're getting. And a grade 1 is not so bad, kind of tolerable, we can get you through it. And a grade 4 it's pretty severe, and a lot of times people have to stop their regimen due to a grade 4. The grading system comes from Health and Human Services and the NIH, and it's a collaborative group of clinicians that established this grading system. Well, financial toxicity has cropped up into that vernacular now because it definitely is causing a response that is unwanted for patients that are undergoing treatment for cancer. It's, by definition, the psychological response to an increased financial burden that's associated with their diagnosis and with treatment. And it's common. It affects 2/3 of all people that are diagnosed with a cancer diagnosis. And it's measured by the amount of financial stress, distress, or worry. So as we move to the next slide, I'm using cancer here because it's relevant. So in 2018, there were close to 2 million new cancer diagnoses in the United States. And there's a 1 in 3 lifetime risk for all of us that we're going to be affected by a cancer diagnosis, either directly or indirectly. The median age, so that the most common age for people to be diagnosed is 66 years old. And out of that almost 2 million new cases in 2018, 63% of them were diagnosed in people 45 to 75. And this data comes from the SEER database as well as the American Cancer Society. So the point here is cancer is going to affect somebody that we know, whether it's ourselves or somebody else. And it's a big problem. So this financial toxicity has the ability to affect lots of people, which is the point of this slide. So let's talk a little bit about what drives financial toxicity. So like when you're talking about a physiological toxicity with a cancer treatment, you're looking at what drives it. Like sometimes it could be a patient's nutritional status, it could be their performance status. There are different things that will drive the toxicities. Here for financial toxicity, the first one is demographics. So we're looking at a financial toxicity is due to just the overwhelming increasing cost of healthcare in general, not just in cancer. And so what are driving these costs are, one, we've got more people that are accessing the healthcare system because the baby boomers are aging. And so we've got a lot of people that are falling into that demographic of, the 5th, 6th, 7th decade of life, which is when a lot of people are diagnosed. If we live long enough, we're going to come down with some disruptive illness. So that's the first thing that drives the high costs of healthcare. The second is just innovation. Innovation doesn't come without a cost, right? So how many of us remember when, flat screen TVs were lots and lots of money, and now we have them in every room of the house, and, as they have come along, the cost goes down. And the same is with a lot of these innovative medicines and a lot of the innovative technology. And I will give you just one example of what's happened since the human genome was mapped. There's just been an explosion of molecular targets and things that can be targeted by the drug companies to make treatments for some of these diseases that we're facing. Multiple sclerosis has had a breakthrough, Parkinson's is continuing to have breakthroughs, and cancer is probably the one that's had the biggest benefit. When you have a cancer diagnosis and your tumor shows that you can have a very specific, sophisticated treatment, that's going to be expensive because it hasn't been out here very long. So we've got those costs to contend with. There's also a phenomenon, overutilization. So overutilization in the cancer world, but it happens everywhere because none of our healthcare integrated systems are as integrated as we'd like them to be. And so we assume sometimes that one specialist is talking to another specialist, and that's not always the case. So what happens is you may have a cardiac condition where your cardiologist has ordered a test, but then if you say, heaven forbid, should have a cancer diagnosis, and now you've got a medical oncologist who's also looking at you, and he's ordering the same duplicate test that the cardiologist just asked for, and instead of talking to each other and potentially using the same test to gather the information, they're just ordering more tests. And so we have an overutilization of imaging for the most part, but it's all different kinds of testing. And then the final thing that really is driving cost is the Affordable Care Act looked really great on paper. However, there's been some unforeseen collateral damage where the insurance companies are shifting a much higher proportion of what we thought they were going to of the cost over back to the individual and the patient. So these are the factors that are actually driving the high costs of healthcare right now, and financial toxicity specifically. So how do we measure financial toxicity? So like I mentioned with the earlier analogy with the regimens and having a side effect. So let's say your blood counts go down to such a degree that you can't sustain treatment anymore and you need to be taken off therapy. That would be like a grade 3 to 4. And if your counts go down just a little bit and you're able to get some growth factor support and continue on your therapy, that might be a grade 1, 2 level side effect. So this measures of toxicity here are going from a least sort of grading all the way down to a grade 4 where it's going to be devastating for a person. So the first one is just how much are your out-of-pocket costs for your treatment going to be as a proportion of your income? Okay, that just makes sense. How much is your income being reduced and your assets being chewed into if you have assets? So how much are you dipping into your retirement, and how much of an influence does your disease have on your ability to generate income? The next is associated expenses. So some diseases are more expensive than others based on like the innovative techniques that are available, the innovative drugs that are available, the imaging that's required. So depending on the expense of the illness, that's going to also drive how this is measured and how it affects you. Your accumulated medical debt will decide like how severe the toxicity is, and your effect to pay for just basic necessities. So I'm sure a lot of you have heard or have even experienced, I'm going to pay my copay for my pills instead of going to the grocery this week. And in really severe cases, people are not paying like power bills, phone bills, so they can pay for their medical treatments and their medical expenses. And then the final, the absolute worst sequelae from the financial toxicity would be bankruptcy, right? So this is somebody that just has to declare bankruptcy because of their medical debt. And that's what we definitely want to avoid. So these are the different levels of how a financial toxicity can be measured. And so just like a patient before they enroll like in a clinical trial or start a new treatment, you want to assess, what are their risk factors so we can sort of get a picture of how they're going to do. And the same goes with financial toxicity. And one thing that I did forget to say that I'd like to just add in here, financial toxicity is starting to become a normal thing, especially within cancer and clinical trial design. So they're not only measuring a person's physical side effects, they want to see how the drugs are working from a physical perspective and the effects they're having on a patient, but they now are actually putting in a grading system to measure financial toxicity on a patient from some of these treatments. So it's something that is beginning to be tested. And some of the factors that we are considering are, so one, the wage earner status. So if you are the primary wage earner in your family, obviously you're going to be at greater risk for being affected by some financial toxicity. If your disease really inhibits your ability to work, then that's going to result in sick days and lost wages, which is obviously going to have an effect on your income producing potential. If you are carrying a lot of just debt at home before you even start a medical treatment, that's one of these high cost medical treatments, you're already starting in the hole. So you're already at a greater risk for accumulating more debt. The presence and the terms of health and disability. So if you've got healthcare and you've got, health insurance and you have disability insurance, that's good. But then how much are they actually covering? So sometimes people will find that their health insurance is not covering as broad it's not as comprehensive as they had hoped it would be. And if you've got less coverage, you're at more of an increased risk because obviously you're going to incur some more out-of-pocket expense. You also, a patient's or a client's current assets. So if they have assets that they can tap into to offset some of these out-of-pocket medical expenses, that's a good thing. If they don't have assets or they don't have access to the assets, then they're putting you in an increased risk for being affected by financial toxicity. We already talked about the illness associated costs. Some are more than others. So oftentimes the more innovative the treatments that are offered or the newer the drugs or the more sophisticated the drugs, the higher the costs. And then if you don't have any other access to income within the family, that puts you at an increased risk. So these are the risk factors that are associated with the financial toxicity. So then moving into, I wanted to just share a reality. This is a real case study of this is how it's affecting people in the real world. So we talk about it and we know about it, but this is what's really happening. So there's an epidemic right now of metastatic colorectal cancer that is sweeping through younger people. So more and more people in their 30s, 40s, and some in their 20s are being diagnosed with metastatic colorectal cancer, which just means it's colorectal cancer that has spread to other places. And the sad thing is, and the scary thing is we don't know, well, I'm not the physician, but epidemiologists and people in the field of colorectal cancer have no idea really why this is. So it's a hot topic right now of trying to figure this out. But in the meantime, this is what's happening. So if you think about somebody in their 30s and 40s, they probably still have children. They're still trying to work, right? They've got their income producing years. And now they're hit with this devastated diagnosis. So a lot of times there's innovative medicines that are offered, that are available for these patients to take, which results in typically a higher copay or a higher deductible. Then there's lots of imaging that's involved with cancer diagnosis. And so you've got your CT scans and your PET scans and all of the scans and imaging, and they run about $2,500 a test. And not all of them are going to be covered under somebody's plan potentially. And then I think this demographic gets hit hardest with the indirect costs because they can't work. They typically they have children, so now they need to pay for caregiving. They have cosmetics. A lot of them, they want wigs. They want to, still look good and feel like they're not sick. And what really sucks up a lot of their resources too is legal services, because they're trying to tap into Social Security and medical disability, and it just, a lot of times it requires some legal help to be able to access those resources. So when all is said and done, and this is not a made up number, this is a number that was pulled from data, it's out over $30,000 a year out of pocket for somebody in this situation. That's not $30,000 a year for the entire treatment. That's what the patient's responsible for. So you can see that this is real. And in some other just numbers, there was a survey that was done by LiveStrong in 2012, and there were 4,000 cancer survivors that were surveyed. So these were people that had already been through their treatment. They were on the other side of their diagnosis. And out of those 4,000 people, 1/3 of them incurred some level of medical debt as a result of their treatment. And even more astounding to that, 2,000 of them, so half of the 4,000, owed more than $10,000 when it was all said and done. And that's what they were left with trying to pay off. So it's a real situation, and it's something that I'm glad is being addressed. And so I'm going to switch gears a little bit, because we've talked a lot about what is the problem, but there are some solutions, and there is a little bit of bright light. The one thing is that we know about it now, and so it's out in the open. And I will tell a story. So part of innovation, I'm going backwards now, but part of the cost of innovation, and I'm not going to bash the drug companies, because I'm just not. They do a lot of good. But whatever you want to say about the cost of drugs, innovation is not cheap. Okay, so it's not like a heart drug where everybody's got high blood pressure, and so they put people on high blood pressure medicine, and they've got a larger portion of the population taking these medicines for long periods of time, which allows the drug company to recoup the cost of all that R&D and all of that for that drug. So those drugs are typically less expensive than some of our innovative cancer drugs. The innovative cancer drugs, we have smaller populations that actually take them for shorter periods of time, and they are extremely expensive to bring to market. So the drug company has a much smaller window to be able to recoup the cost of manufacturing and developing the drug. So consequently, we have drugs that cost a lot more money, especially in the early parts of their being available. So I had a physician back in the 90s who was ahead of his time, and I had the good fortune of working at Genentech back in the 90s, right as all these new immunotherapies were coming out, and it was a very exciting time for cancer patients. And I had one physician who would talk about this one immunotherapy in particular and say it was a fabulous drug. It was revolutionizing patients' lives, but it had one problem, and that is greenopenia. Now, greenopenia is just a play on words for neutropenia, which is, a blood counts that have gone south for patients. They don't have enough blood counts to manufacture their immune system and to keep their immune system going. And he coupled that with the price tag of the new immunotherapy and said that, greenopenia was going to be a problem. Well, this was back in the 90s, and it has all come to fruition. And we now are really dealing with financial toxicity / greenopenia. And so the point of me telling that story on this slide is it's taken a long time for this to kind of hit the radar screen of policy people and people bigger than just, us. And so now we've got in Washington, D.C. and a bill that is sitting in committee in the House. It's HR 1409, and it's called the Cancer Drug Parity Act. And essentially what this bill is designed to do is to bring parity between cancer drugs, no matter what their route of administration is. So I'm going to give you an example. So if you've got somebody who is in the hospital or in an infusion center receiving some older chemo regimens, that is all reimbursed in one way, through one vehicle of reimbursement. If you are, say, the metastatic cancer 30-year-old who's going to the pharmacy to get his cancer medicine that just happens to be a pill, and he gets there, and because it's being reimbursed through a whole nother arm of reimbursement, it's, you know, his prescription plan and all of that, all of a sudden he has a copay or an out-of-pocket of like $4,000 or $5,000 for that prescription and its pills. And that there's something wrong with that. And so the policymakers on Capitol Hill have identified that, yes, that's a problem. And if HR 1409 does go through, that will bring parity to all the drugs, no matter what the route of administration is. Everything will be reimbursed at a fair rate across the board. My fear is that everything on Capitol Hill has come to a screeching halt right now. The productivity on Capitol Hill is very low. And until we finish with impeachment, we probably are not going to do anything else, but it's in the committee in the House right now, and hopefully that's going to go through. The other thing that has happened just in this past week from a policy perspective is the White House has finalized their mandate for hospitals to have price transparency. So we're going to start seeing in the hospitals, they're going to have to start putting line items of their pricing and what everything costs, instead of just going in and finding out after you've had all the procedure. So we'll see how that works out. It's a good idea. We'll see if it actually helps. But those are two things that are happening from a much broader perspective. So to chink it down a little bit more on what we can do, what can we do to minimize the impact of this financial toxicity? And believe it or not, one of the best tools that we have is just communication. So there was a survey that was published in The Oncologist, and it surveyed patients and physicians. And the survey found that out of the patients that were surveyed, 63% of them felt like having a conversation with their clinician about their healthcare costs was a good idea. And 79% of the physicians that were surveyed felt like, yeah, our patients want to have this conversation and we think it's an important conversation. Okay. Well, in reality, what happened was only 15% of those patients that thought it was important actually brought the conversation up when they were with their doctors, and only one third of the physicians actually brought it up. So we're sitting here with this healthcare cost elephant that's in the room and nobody's talking about it. So one of the very first things we can do is just start to ask the questions. How much is this going to cost? And what are my options? And let's be smart healthcare consumers, because the physicians, unfortunately, are not going to bring this up with you. And it's not because they don't want to, but they don't know. A lot of times they don't know how much it's going to cost you. They really don't. So how do we make our communication very effective? And we'll talk about that in a couple of slides from now. Another thing that we can do is just minimize your risk of a hospital stay. So obviously, the less amount of time you're in a hospital, the greater the probability is that you won't incur some preventable events that are going to make you stay there longer. And the longer you stay, not only is there a risk to your physical well-being, but there's a risk that you're just racking up hospital charges. So as a smart healthcare consumer, do some research. And this is a organization, it's the Leapfrog Group. And if you go under hospitalsafety.org, and all of these resources are going to be listed for you guys at the end, so you don't have to write it down. The Leapfrog Group does a great job in doing hospital ratings based on preventable harm. So things that can happen in the hospital that shouldn't, such as infection rate, their MRSA infections and urinary tract infections, as well as you can look up things like how do they do with specific surgeries, what's their infection rate from surgery, all types of things that y'all can look at to say, you know what, that might not be the hospital I want to go to. And so this is a good resource. Another is engage with the institution's financial office before you get the bills. So I urge a lot of my clients to talk to whoever it is, whether it's a doctor's office, it's a hospital, it's an outpatient surgery center, it's a skilled nursing facility. Talk to the person in that building that is most intimately who has the most knowledge around the finances and the billing and the insurance. And they may be called a financial counselor, they may be called a billing specialist, a payment services, insurance advocate, but they're in the billing department or the medical finance department, and they're different levels. Some financial counselors are actually accredited, and those are great, but these guys have resources to they know a lot of resources within the community, within their hospital system, of how to access financial supplement help for their patients. So these are good people to know. The other thing that you can do, and I highly recommend, is engage a private advocate. This is a perfect time to get a private advocate, somebody that has got your best interests at heart, somebody that understands the system, understands the disease, understands the billing process, and can really help you become a smarter healthcare consumer. And any one of these organizations, WASA is here today. WASA is actually sponsoring this webinar for us, but there's also the Alliance for Professional Health Advocates and Greater National Advocates and the National Association of Healthcare Advocacy, and they all can help you find an advocate in your area. Sometimes people don't think about this, but have a life insurance review. So talk to your life insurance agent, because many life insurance policies will have some type of a rider on them where if you're facing a catastrophic illness, you can actually pull out some funds from the life insurance policy up front without penalty to help pay for some of the costs of your treatment. And I also always ask my clients if they have a financial planner or a wealth manager, it's a good idea to review with them, because oftentimes just making a small tweak to your portfolio or to some aspect of your retirement fund can open up some liquidity and some cash for you to be able to help to pay for some of these out-of-pocket expenses. And then we have our nonprofits and our advocacy groups. And I will say there were too many to put on this slide, right? So I just used a couple for an example, but almost every disease state has some sort of advocacy nonprofit attached to it. And here's the Multiple Sclerosis Society. They have financial resources available for patients. The Financial Planning Association has just launched a new program for providing pro bono wealth management, trying to help clients plan for their treatment costs pro bono, as well as just grassroots GoFundMes. And right now we are in such a time where we are very hindered by a lot of our insurance companies, right? So a lot of us are in HMOs, we can't get out of our HMO. But if in the case of cancer, in the case of multiple sclerosis, or a rheumatoid arthritis diagnosis that's really hard to treat, you might need to go get outside help. You might need to go find a specialist that's not in your HMO. That's going to cost you quite a bit out of pocket because it's out of network. And so in cases like that, I tell clients all the time, let's just launch a GoFundMe, because people want to help you. They want to help you, but they don't know really how to help you. And so this is a great way for people to help. And it helps mitigate or to minimize that financial impact for you. And then there's also industry. So I'm going to go back to the drug companies again. So for all the evil that people say the drug companies, we're the bane of everybody's existence, they actually, for the most part, are very generous. There are very generous patient assistance programs and foundations associated with most of the big drug companies. And I'll just give you a story here. I've got a client right now who did not qualify for a clinical trial that was available to receive one of these newer innovative drugs for her cancer for other reasons. They just couldn't take her in the trial. She appealed to the drug company, and they are supplying the drug to her off study for free, and it's keeping her alive. And it's a very expensive therapy that she's receiving. So tap into this resource. It's a wonderful resource. And if you don't get the drug for free, oftentimes they will have copay assistance. Lots of money is out there for patients to get. And one of the best ones is the Patient Advocate Foundation does a good job in really helping people find the right foundation, the right money, the right drug company. Another one is RX Assist is a good one, and Needy Meds is a really good one as well. And these guys just curate all that information so you can go to one place and try to do your best searches for money within industry. And then I kind of use it as a last resort just because there's a lot of bureaucracy and a lot of paperwork, and there's a lot of, not everybody's going to qualify. They've got strict qualifications. And so, but there are government programs. So especially if you've got a Medicare participant, there are programs out there through the government that can help offset some of this financial burden. And finally, we forget about this sometimes, but I really, a lot of times will ask my clients, have you considered counseling? Because there's all types of counseling out there. And one of the biggest ones that can be used in this situation is a solutions-based counseling, where they focus on the solution of this huge problem that people are shouldering the burden of. And if you can get people to a point where they're just checking off little baby steps to move the mountain, it changes their whole perspective and takes off a lot of the anxiety that they're feeling with this burden of this medical albatross around their neck. So counseling is another good avenue to help alleviate the burden. And so I'm just going to end on a positive note, a really positive note. This is a really great, and I had a film clip, but unfortunately it wouldn't work. But if you guys want to Google it, you should just Google RIT Medical Debt and look at the YouTube videos for this. But RIT Medical Debt is a nonprofit that was started by two men who used to be collections people. So all they did was call and harass people for their medical, for their medical payments. And they just became so disenchanted with that and just completely depressed by the whole thing that they quit, and they started this nonprofit, and they go and buy. You make a donation to RIP Medical Debt, and with the donations that they get, they go and buy medical debt for pennies on the dollar. And they buy up, they search geographic areas that are probably the most encumbered by medical debt. So the story is about a community up in West Virginia, but they'll go and they'll buy the debt, and then they send they send cards out to the people whose debt has been just wiped out. They just wipe out just millions of dollars of medical debt for people, and then just send them a card, and it's like winning the lottery. So it's an awesome organization, and if you guys know of anybody that is looking for a place where their money can really have a positive impact in a nonprofit situation, I highly recommend RIP Medical Debt. It's an incredible organization. And with that, I'm just going to let you guys know that all the resources that I talked about are here, and they will be available to you. And here's my information. If anybody has questions or you want more information, feel free to reach out to me. And I'm just really grateful, Robin. Thank you for this opportunity and for letting me be here today.
Thank you so much, Dana. It was, I'm always learning something from you, and especially on this issue, I think it doesn't get covered nearly enough. We had one comment from an attendee who said that one strategy, this is from Michael Wood, who is also on our WASHA Board of Directors, one strategy that is often never brought up when receiving hospital care is to ask the hospital for a charity care application. If they see that they're unlikely to recover what you owe them, then they will write it off as bad debt, or maybe they'll write some of it off as bad debt. So, I think, have you had experience with charity care applications, and is that something you recommend?
Oh, I totally recommend it, but actually I haven't. I haven't had a case yet that I haven't had a lot of hospitalization cases quite yet, but But that, I'm wondering if that's something that, is it just for the hospitals?
Well, they have charity care, if you're unable to pay
Right,
in
but
the
I just wondered
hospitals.
if any of the big, that's interesting, because if, I'll see if any of the big, like,
Hmm.
huge cancer centers, like, are doing something like that. So
Yeah, I'm not sure. I'm not sure.
yeah.
As we're getting a lot of thank yous, Dana, from the attendees here. And while you're formulating your questions, I have a couple questions that I'm kind of curious about that you can help us understand. So you mentioned that there is a lot of overutilization of testing specifically. And one of the things I wanted to understand was, how do either advocates or ordinary patients kind of approach this overtesting conundrum? Like, how do you know if you're having too many tests? What do you say? What can you do to make sure that what you're getting is appropriate?
That's a good question, Robin. So it's really kind of just a mindset that when you go into the hospital or you go into any kind of a healthcare situation, some of us would take more time and ask more questions when we buy a car. So the thing is we have to trust that the physicians know, and the physicians know best. We have to trust that they know more than we know, right? But they're human and they can make mistakes. And so what can happen, and I mentioned it, is you've got lots of specialists now, and the healthcare system is not very integrated. So you can't assume that Dr. A, who's ordered a test, has told Dr. B that he's ordered the test so Dr. B can go in and see it, right? Or they might not even be on the same electronic medical record system. Like, they might not even. So the responsibility falls on us as the healthcare consumer. If you hear a physician that is ordering another CT scan, I'm going to give you an example. I had a client, she had a CT scan in the emergency room. And then when she got to the hospital and the specialist started needing to do what they needed to do, they started ordering a CT scan. And I said, wait a minute, we just got a CT scan downstairs. Can you use the same CT scan? Like, nothing's changed. She's only been in here, 2 days. There's been no change. And it's things like that where he was like, oh yeah, sure, we can use the one they use downstairs. So it's just being aware of what they're asking for. You don't have to understand everything, but then the other question is to ask why. Why are you ordering that test? What new information are you going to get from that test, and how is it going to change my plan of care? Like, just question them. It's okay to push back a little bit.
Mm-hmm. Thank you for that response. I just launched the poll about understanding the attendees and who's actually on the line. So if you can vote in the poll while we're pulling up questions, that would be helpful. So again, from Michael, one good question about whether a test is necessary, and I think he's recommending language. Will this test and its results change what the recommended treatment would be?
Right.
So that's good sample language. Do you have any other sample language that you would recommend either advocates or patients use?
Just very similar to what Michael just said. Just how is this going to change my plan of care?
Mm-hmm.
Or how is this adding to my plan of care? You always want to ask questions about what are the costs of the side effects? Like, if this is going to change my plan of care, how is it going to change me how is it going to affect me physically? Whereas now I might need to be adding more costs in treatment because now I'm taking drugs to mitigate or to, diminish side effects. So it's just what Michael said. It's just how, why are you doing this? How's it going to change what it is that you've already ordered for me? And then understanding what that is. And then you have to run your own cost benefit, right?
Mm-hmm.
Maybe you don't want that PET scan. Maybe you just, so they need the PET scan, but if it's not going to change anything that they're doing from a treatment perspective, they just kind of want to check and see if it's, whatever. No, you don't need that. That wasn't the answer. I'm sorry, but I just get wound up about
Well, and this is from Melanie, one of our attendees. She says, it's worth asking, what is the question we're trying to answer by doing this test? That's an excellent language, I think, and suggestion. And while we are still pulling in more questions, I launched the second poll, which is, have you ever heard of financial toxicity before this webinar? And about half of the people have voted who are on this call. And it's interesting because 71% had not ever heard of financial toxicity. So I think this is really still a very new concept. And I guess another question for you is, do you think it will likely be applied in the fields outside of cancer where this is maybe a more common concept?
I do. I do. Maybe not from a clinical trial perspective, right? Maybe they're not going to start, putting it in with clinical, but I do feel like the terminology is going to catch on because all of these, there's toxicity associated with every therapy. I mean, there's a side effect associated. So maybe it won't be toxicity, but maybe they'll be calling it financial side effects. But I do believe that it will permeate through to other disease states because we have biologics now. We have cancer is not the only place where we have high cost innovation and so it's going to start to permeate anywhere where you've got these treatments and these technologies that are expensive.
Yeah. I have a question too about whether or not financial toxicity specifically or more especially affects certain patient segments. Like, are there additional or greater impacts if you are a certain ethnic origin or gender, or is there any research or anything on that?
Yeah, that's a good question. And there's not yet, Robin. It's so new that those are some of the types of data that they're going to try to tease out as they're building financial toxicity into research. Those are some of the things that we'll be able to start to glean. But right now, no.
So for the advocates, it looks like the majority of people who are on this particular webinar, at least 2/3, are either advocates or allied health professionals. So for those people in the audience, can you give some suggestions as to how they can help their clients frame financial toxicity as they get engaged with the client? Is there some kind of framework similar to what the cancer counselors do on the slide that you took us through? Are there some kind of simple set of questions, or is there any kind of standard approach to that you would suggest advocates use?
Yeah, no, that's a good question. So I've got a document if people, want to reach out. I do have a document that I'm happy to share that helps to frame that conversation with advocates as well as for patients, so my clients, to help them. One of the things is when we looked at, if you go back to the slide of what the risk factors are for experiencing some type of a medical burden, right? And it was things like, are they the wage earner status? And so you want to frame your questioning or just frame your intake with your clients and just incorporate some of those things so you can see what the associated risks are. And if you do have a client that is, has 3 or more of those risk factors, then you may want to start having bringing in more of the financial resources for them sooner rather than later. But I do have an algorithm that I can share with people.
Okay.
It sort of goes through that. Yeah.
Yeah. So Michael Wood writes, a relative of mine had a quadruple coronary bypass and anticipated $6,000 on copays and coinsurance. Gulp. This is typical annual out-of-pocket for people with any hospitalization, not just cancer. So is there anything that we could be doing, either advocates or WASHA, that could be helping support, elevate the issue of financial toxicity, or training people to have that in their mindset Is there anything that we could be doing better, more?
I mean, that's a good question. Just looking at the poll here, where we've got, 75% of this population has never heard of it, and then blow that out to the rest of the country. So maybe just putting together some type of an educational piece that is available, webinar, maybe not a webinar, but maybe a video, or just something that we can start to use to just build awareness. I think your book, Robin, is a great way too, because you've got this included in your book. And so, getting that in the hands of people. But I do think it's an awareness, it's an awareness problem, right? And so I know I partner with financial planners myself, like with my consultancy. I partner with financial planners, and we do seminars, and I do lunch and learns and things for their clients, where I actually present on financial toxicity to try to better educate their clientele. So I think anything that we can do as an advocate locally in your own community too, just to build awareness. But financial planners for me, wealth managers, have been a big community that has grasped onto this because they see the devastation of it, and they want to educate.
And what are the big or top questions that are being asked in those sessions of the people that attend those sessions? Like, is there a theme or anything in terms of what is?
So this is what I hear all the time. How can I navigate out of my healthcare system and not incur all these out-of-pocket costs? Like that comes up all the time. And then people just want to know they want to know how to be the best healthcare consumer. What should they be looking out for? How to read the medical bills. They don't, understanding an EOB, all of those things. They want to know, how can I be smarter at this? And so I think it's just helping people not be afraid to engage in a conversation with the healthcare personnel. Like I said, we do it when we buy houses, and when we buy cars, and and here we're buying, our health, and we're just kind of letting people just tell us whatever. So the biggest question that people have are just how to do it. Like, what's the theme? Like, I don't know where to start. Like, people don't know where to start.
I know that when we were prepping yesterday, you mentioned that you also partner with insurance advocates.
Yes.
So how does that work exactly for you?
So for me, sometimes people are trying to navigate outside of a health insurance system because they're dealing with cancer, right? So they want to get a specialist potentially, or be on a clinical trial somewhere that's outside of their network, and their network's not going to pay for it. And it can be very, very complicated. And I enjoy battling with insurance, but I don't pretend to know like all the ins and outs. So I pretty regularly, when needed, will reach out to a colleague and just say, in this one, you are the expert on this one. I got the medical part, but you got to help me with this one. And then we'll collaborate together, and it's a win-win. Or there's times where I've gotten clients who've got nothing but a sort of a financial burden issue. They've either accumulated a lot of debt, they don't know how to get out of it. And I will definitely feed those off to the advocates out there that are much more versed in insurance than I am.
And I just want to remind the attendees of this webinar that if you are looking for people that specialize in insurance advocacy, WASHA has at least one, if not two people who focus just on that solely. They're excellent. And other national directories also have advocates that specifically focus on insurance or medical billing, which is really helpful for those advocates who don't want to deal with that. I'm going to ask the attendees, what other information would you like to see or have or curious about from Dana while we have her for just a few minutes more. I want to make sure that we're answering your questions, but also if there are areas that you would like to see in the future related to financial toxicity or this issue at all, just go ahead and type it in the chat function or the Q&A, window, which I haven't actually seen anybody use the Q&A window. So, because I know that you guys are still out there, because I see you. I see that there are still a lot of people signed in to the webinar. So anything that you want to address finally? And if we don't have anybody who has any additional questions or anything to share, which we would welcome, I just want to wrap up by saying that if you would like a follow-up summary of many of the tips in this presentation, you can send an email back to info@washa.org. And if you would like to contact Dana, her phone number is 703-403-7600. I know there's at least one person who's dialed in just by phone, and her other information is there on the screen. After the conclusion of this webinar, you'll see a survey, and we kindly ask that you fill it out. It just takes just a few minutes. We so much value your feedback, and it really helps us to prepare for other webinars and to understand if this is still a valuable service to you. If you signed up for a CEU, a continuing education unit for board certified patient advocates, you need to fill out the survey in order to receive your CEU certificate. If you do not have time to fill that out today, you will be receiving an email tomorrow for you to fill out. If you have any questions or you're interested in joining our efforts, please visit us at www.washa.org, or you can call us at 206-377-3000. I just want to thank you for your time today, and we hope that you found this useful. I know that I thought it was really good information that I learned a lot today, Dana, so thank you so much for taking the time. We look forward to hearing more from you, and if you have any questions, contact us. We're getting a lot of thank yous, Dana, so thank you so much for your time and sharing your wisdom today. Really appreciate it.
I'm grateful. Thank you, Robin. And thank you, everybody, for taking some time.
Okay, bye-bye.
Bye.